Good evening, and thank you for joining us. I hope that you are all safe and well. I am Chiara Ghetti, the current NASPOG president. I'm excited to welcome all of you to the first in our 2021 NASPOG webinar series. As you all know, COVID-19 upended our dream of meeting in person in April, and we're grateful to see all of you and to be able to offer you the NASPOG 2020 program in this revised format. Please share the webinar information with your friends, colleagues, and trainees. And as a reminder, trainees can attend for free. I would like to take a moment to thank the tireless efforts of our volunteers, members of the 2020 Planning Committee, the NASPOG Executive Board, and our Chief Operating Officer, Colleen Hughes. I would also like to thank Washington University School of Medicine in St. Louis, Department of Obstetrics and Gynecology, for their generous donation to our educational program, as well as Fairing Pharmaceuticals for an educational grant. A special thanks also to those of you who have graciously donated your registration fees. $1.25 CME credits are offered for each webinar session through Washington University in St. Louis Continuing Medical Education Department. This is the disclosure statement for Washington University, and each speaker will disclose any conflicts of interest at the start of his or her presentation. Before I introduce our two speakers, I'd like to go over some webinar housekeeping items. The webinar will be recorded for on-demand access. All attendees are in listen mode only and are muted. The webinar will feature a 60-minute presentation followed by 15 minutes of questions and answers. If you have questions for the speakers, please use the Q&A button at the bottom of your Zoom screen to ask questions. Use the chat feature for any technical issues. There will be staff standing by to assist you. The Washington University CME department will email each of you an online evaluation within a few weeks of the webinar. Please make sure to complete this in order to obtain CME credit. Today's webinar is on the topic of effective perioperative mental health interventions for older women. I'm pleased to introduce our two presenters, Drs. Eric Lenze and Tanya Wilds. Dr. Lenze is a geriatric psychiatrist at the Washington University in St. Louis. His research focuses on treatments for depression and anxiety in older women and adults, He will discuss unique challenges to effective interventions for the perioperative population, which are often frail, multimorbid, older adults in perioperative settings, and will address the combined behavioral and pharmacological intervention that is needed to target depression and anxiety. Our second speaker, Dr. Wilds, is a geriatric oncologist at Washington University in St. Louis. Her research focuses on improving geriatric outcomes following oncologic surgery, particularly by recognition and treatment of depression and anxiety. Dr. Wilds will cover downstream consequences of untreated depression and anxiety and approaches to mitigate them. Thank you both for being here today, and I will now turn it over to Dr. Lenze to begin.
Okay, thank you, Dr. Getty. I'm going to get my slides up. All right, hopefully everyone can see what I'm seeing. Again, hi, I'm Eric Lenze, and you'll get to hear from a pair of rare birds. Tanya Wilds is the only geriatric oncologist, I believe, at Washington University. I am the only geriatric psychiatrist as well at Washington University. And what we're going to describe is findings from some old research and then recent research our team has been doing under the auspices of what we call the Center for Perioperative Mental Health at Washington University. Here's my disclosure. So I think most of us are clinicians on this, and I think we like to think in terms of cases. So I'm hoping this case will get us all thinking about the same framework. What's the importance of getting to better perioperative mental health care? Imagine this case of a 75-year-old, so an older woman, admitted to the hospital for a gynecologic surgery. But she has clinically significant depression, but alongside that, co-occurring mild cognitive impairments. These go undetected in the hospital, though. And further, the medications she's taking include a benzodiazepine and a bladder medication, both medications that are known to cause cognitive impairment, falls, and delirium. And this is someone who's about to undergo an operation and a hospital stay. She is taking an antidepressant, but at a low and ineffective dose. And she's not receiving behavioral treatment. So this might sound familiar to you. For me, being someone in geriatrics, it certainly sounds very familiar. And I would ask you to ponder this. What do you think is going to be her outcome during and after this hospitalization? And further, what could be done to improve this outcome? I'll try to answer those questions during this talk. So the concept or the topic of perioperative mental health is really two tsunamis meeting. If you're in geriatrics, you've probably heard of the silver tsunami, which is the aging of the older adults population. You may be less familiar with what's called the surgical tsunami, which is that more and more people are getting operations. In fact, the average American in their lifetime will get something around 9 operations, including minor procedures during their lifetime. Why is this an issue for mental health? Well, depression and anxiety are very common in older adults perioperatively. For example, one study found that 30% of older adults in perioperative settings had clinically significant depressive symptoms, and 24% had clinically significant anxiety symptoms. These are magnitudes higher than rates of clinically significant depression and anxiety in healthy older adults in the community, where you might see rates more of the 5 to 10%. Further, anxiety and depression in this setting have a negative impact on the patient experience. I describe patient experience broadly here. I'll talk about it more specifically later. But in general, what we see is a problem where depression and anxiety coincide with cognitive impairment and polypharmacy, often of hazardous medications like ones I described before, to lead to higher rates of falls, delirium, persistent pain, and impaired recovery, and ultimately to poor quality of life after the operation. And well, what do we do about it? Well, I guess you know the old and I would argue outdated model is if a patient's in a hospital and is suffering from problems, you call psych, right? Call a psych consult. I asked a colleague who his entire practice is perioperative, and I asked him what he thought of that. I said, what are the common problems you see? And he said, we see a lot of psychiatric problems in the hospital perioperatively, in particular suicidal ideation, agitation, what to do with psychiatric meds. I say, oh, okay, so what do you do with these cases? Do you call a psych consult? And he goes, rarely, because it's not helpful. So the model we have for managing perioperative anxiety and depression is arguably outmoded and unhelpful for the vast majority of cases. So we think that innovations are needed in this field, and we think innovations are possible. If we look to the past, what perioperative care was like, it was care focused just on the specific operative problem. If you went in for a knee replacement, the surgeon really only cared about the knee, not the rest of the person. And perioperative care was solely focused on the success of the operation, as well as, of course, the survival of the patient. As the population has gotten older with more medical problems and more frailty, recent and emerging innovations such as what's called ERAS, Enhanced Recovery After Surgery, has developed a model that includes such innovations as preoperative physical optimization, so-called prehabilitation, as opposed to rehabilitation, early mobilization, and post-operative physical rehabilitation. But we think what we need for these common cases of perioperative mental health problems is truly whole patient care, physical, mental, and cognitive health being cared for in the perioperative context. And how would that be done with behavioral and medication optimization interventions delivered not just to the right patient, but at the right time? So last year, our team, which consists not just of Dr. Wilds and myself, but a large group of individuals at WashU, got a pilot grant from the local Institution for Clinical and Translational Sciences to form a collaboration between mental health specialists and surgical specialists, people like surgeons, anesthesiologists, inpatient nurses, and pharmacists. That is to take two fields that generally don't interact much and exist in their own silos and get them talking together and collaborating. And importantly for this center to identify needs and solutions for good perioperative mental health care in older adults and conduct some research in that area. So here's what we found. First of all, we conducted a qualitative study asking multiple stakeholders, older adults who had perioperative problems with anxiety and depression, their family members, and providers, physicians, nurses, and other providers in perioperative settings. We asked them what were the challenges, and we asked them what they thought could be solutions. I'm listing below the publication that describes those findings, but I'm going to summarize them here in a nutshell. First of all, the patients and the family described as a major challenge a limited understanding of what to expect regarding surgery and recovery. They were really overwhelmed by the whole process. And as I understand from colleagues this year, that feeling of being overwhelmed has only been magnified in the wake of the COVID pandemic and what it's been like for older adults to be hospitalized and undergo surgery in this environment. And furthermore, a challenge that in particular physicians and other providers noted was an overwhelmingly complex medication management. That is to say, what to do about antidepressant medications and other brain-affecting medications in these older adults while they were about to undergo an operation and then recovery from it. The stakeholders agreed that a bundled mental health management intervention that was comprised of both behavioral and pharmacologic strategies would be useful. They agreed that it could help mitigate anxiety and depressive symptoms. However, it was clear from talking to hospital staff that they would have neither the time nor the expertise for learning a bundled mental health intervention or carrying it out. The first part of a bundled mental health intervention would be to screen for anxiety and depression. We proposed that our team looked at many different methods and measures to screen for anxiety and depression perioperatively, and came up with this, what's called the PHQ-ADS, or Patient Health Questionnaire, Anxiety and Depressive Symptoms. I'm guessing that many, if not most of the people on this talk are familiar with the PHQ-ADS. It's simply a combination of the PHQ-9 and the GAD-7, which is basically the anxiety version of the PHQ-9. And this is a very simple way to screen patients both for the initial presence of depressive and anxiety symptoms, but also to track symptoms over time and determine whether people are responding to symptoms. With respect to a behavioral intervention, our team determined, based on a literature search and based on interaction with stakeholders, that behavioral activation may be an ideal intervention for this setting. I think probably many, if not most of the audience is familiar with behavioral activation, but I'll just run through it very quickly. Behavioral activation is both a component of cognitive behavioral therapy, and it can be delivered as an intervention in its own right. And in fact, there have been many clinical trials, including in older adults, demonstrating the benefits of behavioral activation. What it is simply an understanding that depression as well as anxiety is linked to inactivity, and behavioral activation is an effort to get individuals to make goals of doing more of what matters to them. For example, to set a goal to exercise 3 times a day, for example. And then both from becoming more active, but also in succeeding toward their goals, it then improves their depressive symptoms, becoming more of a self-reinforcing behavior. Some of the nice things about behavioral activation as a perioperative intervention, realizing that this is a pretty fraught setting where it would be quite challenging to deliver a very complex new intervention, is its pragmatism. It's a very flexible intervention. For example, it can be delivered over the phone via telemedicine. It can be delivered via a small number of visits. It could be delivered to even homebound older adults. It's a very patient-centered intervention in that the patient chooses which activities and goals to work on. Interestingly, my colleague, or our colleague here, Ken Friedland, and a psychologist here who's done many pivotal clinical trials in the area of cardiac disease and medical illness, has found that behavioral activation by itself is about as effective as a package of CBT for depression, as well as for anxiety. And again, as I said, it's effective in older adults. But is it feasible, and who would do it? After all, the hospital staff said essentially, "Not me. We're not gonna do it." It occurred to us that probably the largest group of individuals who might feasibly be able to do this would be not hospital staff, but community social workers. After all, only a small percentage of the perioperative period is spent in a hospital, with most of the perioperative period spent either preoperatively at home or postoperatively in various care settings or at home. So it wasn't at all clear that hospital staff even would be the right individuals to carry out a behavioral intervention. So this year we carried out a survey with National Association of Social Work members whose primary practice area was mental health. We ended up surveying 115 members of the association and asked them, first of all, would it be feasible, do you believe it would be feasible for you to conduct behavioral activation with older adults before and after surgery via telephone? 91% said it would. We also asked them about other possible activities like mindful meditation activities and cognitive training activities. And they also felt that these potentially brief pragmatic interventions were quite feasible as well. Our conclusion is that community social workers are at least confident in the feasibility of these of being able to carry out these behavioral perioperative interventions for older adults. What about the medication side of this equation or this bundle? I have to say one thing that's very different about geriatrics now compared to when I first got into geriatrics, let's say not that long ago, but frankly it was in the 20th century, so I guess it was. When I first started as a geriatric fellow, it wasn't uncommon to see an older adult taking 0 psychotropic medications. Nowadays, it's not uncommon to see an older adult taking simultaneously 6, 7, or 8 or more psychotropic medications. Patients we see are on a lot of medications, and more they're on a lot of medications that affect the brain in some way or another. This isn't just psychiatric drugs that we as mental health providers prescribe. It's psychiatric drugs that other non-mental health providers like primary care providers prescribe. But it's also medications that aren't even considered psychotropic drugs that enter the brain. I think many of you, because this is in the OB-GYN organization, are quite aware that, for example, many medications for overactive bladder, which are commonly used by older adults, particularly older women, can have profound mental, or I should say cognitive health effects. And finally, often below our radar, unbeknownst to us, these older adults are also taking over-the-counter medications like Tylenol PM that enter the brain. So from this, again, what our stakeholders described as an almost bewilderingly complex picture, how do we simplify it down to a straightforward algorithm of deprescribing? Personally, I'm not fond of the term polypharmacy because it groups together one individual who is on 6 medications that are perfectly benign and that they ought to be on, with another individual who's on 6 medications that are harmful or interactive with each other in a bad way. And it also ignores that someone might be on just 1 or 2 medications, but if they're harmful, that's problematic. So what we propose is a deprescribing that's focused on medications that you might call low-hanging fruit as medications ripe for deprescribing. Broadly, these are in 2 categories, and the strategy for them is different. There are first benzodiazepines and similar sedatives, drugs like the so-called Z drugs like Zaloplan, zolpidem, which is of course Ambien, and S-zopiclone, hence the Z drug moniker. These drugs, unless taken at low dose or infrequently, cannot be stopped, but they can, and we believe, when possible, should be tapered prior to the an operation in older adults. I will not steal Dr. Wild's thunder, but I'll let her talk more about why to do this. At the same time, many older adults are taking strong centrally acting anticholinergics and antihistamines. This includes allergy medications like diphenhydramine, as I said before, bladder medications like oxybutynin or tolterodine, bowel medications like hyoscyamine or dicyclamine, and tertiary amine tricyclics like amitriptyline, imipramine, and doxepin. The goal here in deprescribing is that tapering is rarely needed and that these medications can be stopped, and preferably stopped preoperatively. So deprescribing is one aspect of the pharmacologic side. The other aspect is medication optimization. So what do I mean by that? I would say, first of all, the perioperative period for older adults is probably not a great time to start new antidepressants de novo, okay? There's not a whole lot of evidence that antidepressants even work in this advanced age, highly medically ill population. And there are questions as to whether starting a new antidepressant in an individual who's both of advanced age and medically ill and about to or recently undergoing an operation might be doing more harm than good. On the other hand, though, many, in fact, we found in the study I mentioned before, actually most patients are taking suboptimal doses of antidepressants. So a simple medication optimization strategy simply would be to increase the dose in order to maximize efficacy. In other words, if they're not on a medication, now's not the time to start one. But if they are on a medication, optimize the dose so they get benefits from it. How do you dose optimize antidepressants? Using a scale like the PHQ-ADS, it can guide you by telling you whether their symptoms are elevated, thus do they need a dose increase. But you can start by targeting a dose that maximizes the balance between safety, efficacy, and tolerability. And then if you follow an individual long enough, screen them for whether their symptoms are elevated, and if so, they would need a dose increase. I pasted here for your interest a very nice dose response meta-analysis published last year by Furukawa et al. That contains evidence-based optimal doses of many of the most common medications used to treat major depression. Again, to a geriatric psychiatrist with 20 plus years experience, medication optimization and deprescribing may seem well within our wheelhouse. For someone who does not spend every day doing this, it may feel a little bit out of your area of expertise. We think that that one way to make this pharmacologic side of perioperative care more feasible is utilizing pharmacists. Increasingly, hospital systems offer e-consults to pharmacists. Within our own system, the BJC and WashU system, I'm just demonstrating especially for those of you within the system, that's even actually available in our system. You could order on any patient a referral to medication management services. And then I'll get back to what I mentioned earlier, which is patient experience. We need to in our research studies, we need to measure outcomes that matter. And increasingly, it's clear that patient experience is an outcome that matters to all stakeholders, particularly in the perioperative sector. Patient experience is it's an evolving concept, and I think to many of us clinicians, a relatively new concept. But it's a multifactorial concept referring to many things, not just including clinical effectiveness and safety, but patient satisfaction, the feeling that care is personalized, the feeling that of whether patients are engaged in their care, and process issues like the admission and discharge process. So it's a multi-component outcome, but there are what we would argue based on our center's experience so far is that intervention delivery should not just focus on the traditional outcomes such as symptomatic improvement, but needs to focus on the patient experience. Maybe more bluntly, interventions that produce improvements in the patient experience are interventions that are more likely to be implemented in hospital and other settings. And here's a recent study that talked about variables of patient experience and how intervention delivery and the hospital system could be designed around improving patient experience. And two ways that we think are quite relevant to perioperative mental health interventions are listed there under 4 and 5, including family and patients in medical discussions, and consolidating programs with associated support services for both patient convenience and continuity of care. As a result of this, the goal of our center is this bundled intervention strategy, thinking about the perioperative period as an entire continuum spanning from a preoperative to an in-hospital and post-operative period. In fact, many of you who are perinatal mental health experts may feel like we're stealing your ideas here to come to a continuum like this. I do see that there are some similarities. But the preoperative period would be focused on what we call a patient preparedness for surgery. Here I'm talking about a mental health and cognitive preparedness for surgery. Provide behavioral activation to build resilience. This is a time for pharmacologic optimization to reduce risk to patients and ensure their adherence, and to support the family, remembering that patients and family told us that the whole process was bewildering to them, and they felt overwhelmed by it. They wanted to be mentally prepared for surgery. And then in the hospital, coordinate with the inpatient and post-hospital hospital clinicians, continue these interventions throughout that inpatient and post-operative, post-hospital period, realizing that these patients are going to go, these older adults are going to go through many different sectors of care. They may be in an ICU, then a step-down unit, then a rehab hospital, then a nursing home, then getting home care, often with bounce backs during that time. Someone is needed to coordinate their mental health care and cognitive health care within all these settings, but also to try to continue these interventions during that time, so making sure that the gains from the preoperative period are not lost as patients shuttle through these sectors of care. And finally, to give voice to the patient experience in communicating that with healthcare staff. One of the most interesting pieces of feedback we heard from patient stakeholders was, I really wish that the hospital staff knew how I felt. So I'm going to stop here and just turn things over to Dr. Wilds for her part. But I think that I hope you feel like this is an exciting sector of care, perioperative mental health care, where I think we in mental health haven't spent very much time there, but maybe we need to now. We need that. There's very promising strategies, I think, for screening, behavioral treatment, medication optimization, and deprescribing. And I think the opportunity to start treatment early and then continue that treatment through the period of risk. And how we plan to study this is to take these interventions that we described, make stakeholder-driven adaptations, measure the intervention's effectiveness for outcomes that matter, and disseminate what's effective. I look forward to hearing both questions and advice from my colleagues here in our Q&A period. Now I promise I'm going to turn things over to Dr. Wild.
Great, thanks, Eric. So I'm going to continue from here and talk about the downstream effects of depression and anxiety, focusing on older women. As a geriatric oncologist, I tend to focus on older women with cancer, but I think the same concepts apply across other chronic disease conditions. So we'll talk about cancer outcomes and optimizing function through prevention of falls. So here are my disclosures. And again, one of my disclosures being that I am a medical oncologist, and so I tend to see the world through cancer-colored glasses. So I apologize to those of you for whom that's not the world you live in, but again, I think a lot of the same concepts are going to be applicable across other chronic conditions in older women in general. So the objectives for my time here today is that I'd like to talk about the sequelae of depression in the perioperative period that extend beyond simply the adverse effects of the cognitive and symptom burden on those patients. I think that for this audience here, they need no further incentive than the direct direct benefit of helping alleviate that suffering of patients suffering with depression and anxiety. But for those that, as Eric mentioned, may just see the knee surgery as focused on the knee, we want to broaden the perspective of the potential benefits of addressing depression in these patients. We're going to talk about risk factors for falls, of which depression and actually antidepressants and other centrally acting medications are a prominent component. And it's actually through that back door that Eric and I connected. It was my interest in falls that led us to collaborate. And we'll talk about why falls are such a robustly predictive tool or concept for adverse outcomes in older adults. So to start with, I'd like to point out some of the literature about the adverse outcomes of depression in the perioperative period. Among the studies that are currently available, large data sets have demonstrated the adverse outcomes of depression associated with depression in the perioperative period. That can include increased risk of postoperative and intraoperative complications. And of note in particular, women who had gynecologic malignancies were in this mixed cohort at particularly increased risk of adverse postoperative outcomes, which was further exacerbated by the presence of depression as well. We also know that the presence of preoperative depression increases the risk of postoperative delirium by 30%. This is particularly problematic because delirium can result in prolonged persistence of cognitive impairment, further impacting the potential for physical rehabilitation, resulting in frailty and poor recovery from the surgical period. In patients with cancer, the presence of depression is actually independently associated with likelihood of the cancer recurring. I list here two separate studies which demonstrate the same thing. Unfortunately, neither of them are in gynecologic malignancies, so that would be low-hanging fruit for any trainees looking for a project, is that it would be very key to know that this same phenomenon is present within women who are facing gynecologic malignancies. But on the left, I detail a large cohort study looking at the serum Medicare data of older adults who had muscle-invasive bladder cancers. And depending on the number of psychiatric diagnoses present within the billing codes, they had greater likelihoods of their cancer recurring, resulting in poorer cancer-specific survival. So this variable removes other causes, other comorbidities as the cause of death. So patients who had depression and other psychiatric conditions were at greater risk of cancer recurrence. And very importantly, they modeled the psychiatric diagnoses as a time-varying covariate. So this mitigates the potential criticism of this study that patients who had their cancer recur were more likely to develop the psychiatric complications thereof. In this study, they modeled that they did the multivariate modeling so that they were ensuring that the psychiatric comorbidity predated the cancer recurrence in their modeling. In another cohort that where patients were individually underwent psychological screening, psychological distress, which was a hybrid of depression and anxiety, was independently associated with increased risk of recurrence for their cancer. Specifically in a gynecologic malignancy with serous ovarian cancer, when they looked at women who lived shorter than or greater than 7 years, depression was independently associated with, depression at baseline was independently associated with poorer survival in these women. And when I first heard about this link between cancer recurrence and depression, I was absolutely perplexed. It wasn't intuitive to me why this link would be there until I began to explore the profound physiologic complications, physiologic impact of depression symptoms. And there was just a really lovely systematic, or I should say, review cited here that describes the manifold impacts of depression on the physiology, including increased inflammation, reduced immunosurveillance, autonomic dysfunction, and dysfunction of the hypothalamic pituitary adrenal pathways, which then, in fact, in turn, impact the risk of cancer. So, for example, immunosurveillance is an important component of our reducing the risk of cancer and so forth. Cancer cells love inflammation as a driving force as well. So switching gears from here, I'm going to talk about my primary interest in falls, which then led me to an interest in mental health. So, as many of you have probably also experienced, great clinical questions come from the clinic, from seeing patients, from seeing what they're struggling with. And heading up on 10 years ago, I realized as I kept walking into my exam room and seeing my patient, my older patient with a black eye, and asking them what had happened, and they hadn't called with any problems, finding out that they'd fallen, and realizing a few things. Number one, oftentimes they assumed that falls were a normal part of aging, and that there was nothing to be done about it, and if they didn't need emergent medical attention, it wasn't worth mentioning. And then secondly, how greatly I was impacting their risk of falls. Number one, I give chemotherapy, which causes neuropathy. Number two, I used to give benzos with great freedom because we often use it as an antiemetic. And even the SSRIs have a potential impact on the risk of falls. So my first step when I decided I wanted to really investigate falls in older adults with cancer was hitting the literature and realizing that in fact older adults with cancer are at greater risk for falls than the general population. In a very vulnerable cohort, up to half of patients were falling over a 6-month period. This compares to the non-cancer population, where the widely cited literature is about 1 in 3 older adults over the age of 65 will fall each year. And we know that there's, in addition to fall-related injuries, there are a host of other adverse outcomes of falls, including patients developing a fear of falling. They tend to go out less for fear of falling. They then experience functional decline and then are ultimately at increased risk for ending up entering a nursing home. And particularly important for a medical oncologist and for my gynecologic oncology colleagues who may be in the audience, they they are then at increased risk for chemotherapy toxicity. And unknown to many patients, falls are potentially preventable, but before we can decide, or before we can attempt to prevent falls, we need to know which individuals are at greater risk to then refer them for intervention. So I took to the literature again to do a systematic review of the factors associated with falls in older adults with cancer. And you will see in this last column here that among the dozen or so articles reviewed, a number of them did demonstrate an association between depression and falls. But the black box indicates here that some of these studies did not demonstrate that falls were statistically significantly associated with falls. So as you can see, kind of across the board, it was really unclear what the risk factors for falls were in a patient's population selected for older adults with cancer. So I had the opportunity to work with the Cancer and Aging Research Group, developing and internally validating a model of factors associated with falls. Dr. Arthi Huria is the late founder and leader of our group, and she had a wonderful data set of 500 patients on whom the patients had completed a geriatric assessment prior to initiation of chemotherapy. Included among the questions was whether they had had a fall in the past 6 months, and then a number of other domains of geriatric assessment. And what we found was that in a comprehensive modeling approach, these 9 factors were those that created a model that had the best fit predictive of factors associated with falls. Now, this was a cross-sectional study, so the patients who had had a fall, we couldn't tell what was the chicken and the eggs. That we knew in advance that we were going to need a prospective study to demonstrate the predictive ability into the future. So, but what we found was that patients who reported that they felt slowed down, who had a prolonged time on the time up and go, which is a test that requires the patient stand up from seated, walk 10 feet, return to their chair, and sit back down. If they had a longer than average time to complete this, they were at a greater risk for having reported a fall. Any limitations in the instrumental activities of daily living. Those who had depression based on the hospital anxiety and depression score. Those who had impaired renal function. Polypharmacy, apologies, Eric, that we just use the garden variety polypharmacy measure here with the cutoff of greater than 4 medications. Oops. Those who are on antidepressants, this was predominantly SSRIs were at increased risk for falls, as were those who used benzodiazepines. And as I was less familiar with the general falls literature at the time that we conducted this, I had to really hit the literature to understand this. But in fact, this association between SSRI use and falls has been described. And what was of particular interest to me was that it wasn't that the presence of SSRIs were a marker for symptoms of depression and vice versa. Independently, both depression and antidepressants were associated with falls. What these calibration plots show is how our model did at predicting who fell. So the gray line is what the model would predict would be the rate of falls in a patient who had each of these scores based on the prior scoring system. The red dots here demonstrate what was the actual observed rate of falls in our cohort. The larger the circle, the more patients that are creating that data point. And as you can see, the red dots are pretty close to the gray line, demonstrating decent fit of the model and calibration. We then validated in a separate 250 patients, and again, you can see our dots are pretty close to our line, not perfect because we did have a little bit of a drop in our AUC there. So subsequent to that, I thankfully obtained funding for and developed a protocol to prospectively validate this. And I went in with 2 risk factors. One, that older adults with cancer have unique risk factors for fall, with our aim being to prospectively validate the fall risk model we had developed previously. My other main hypothesis is that fall risk factors for older people with cancer is dynamic and that we need ongoing risk assessment. In patients who are receiving chemotherapy, which this population was studying, things are changing really fast. Within 1 cycle of chemo, 17% of patients will have developed a new new dependence in instrumental activities of daily living. So basically, visit after visit, they can be potentially acquiring new risk factors. We aim to enroll 200 patients who are over the age of 70 and undergoing systemic cancer therapy. We completed a baseline geriatric assessment, and then we reassessed them at each clinical visit, trying to mirror as closely as possible clinical practice, rather than requiring that the patients undergo their follow-up serial visits at predefined times, which may not have coincided with their ongoing cancer care. We assessed falls using a rigorous method of monthly falls calendars. Interestingly, it's actually very difficult to get accurate falls data. People don't remember well. So if you just ask them retrospectively, have you fallen in the past month or fallen in the past 3 months, their recall is relatively inaccurate. So what we did was provided each patient with a personalized calendar for which they would prospectively mark which days they had falls on. So that study is complete and analyses are just starting. Unfortunately, my model's not working out so great. We hit exactly the number of falls we were anticipating. About 25% of the patients fell over the 6 months of follow-up, but we're finding actually that prior falls is currently the strongest predictor. So I'm probably going to need to stratify to identify those older adults who are having their first fall. So we'll have both the primary prevention and secondary prevention models. My dream is ultimately, once we have a good model, that when a patient shows up to be seen in clinic as part of their rooming procedure, the patient could be asked, do you feel slowed down? Do you need help taking your medications or other IADLs? And then the electronic medical record pulls in renal function, it identifies polypharmacy, it identifies these high-risk medications we've been talking about, and prompts us with the patient's particular fall risk and offers options for management of this patient to reduce their fall risk. For example, referral for medication management, as Eric mentioned earlier, referral for occupational therapy to complete a home safety evaluation. For those of you who may not be familiar with this offering, occupational therapists are trained, their occupational therapists can be trained in evaluating the home for areas that may be at high risk from environmental hazards for falls. And it's very interesting how our patients, and I do the same thing, we stop seeing our environment. I don't see the piles of paper on my counter after a certain amount of time. The older adult may not see that throw rug that presents a falls hazard. The occupational therapist will look at it with look at the home environment with the eyes of safety and provide recommendations, things like adding a grab bar, a railing on the stairway, and so forth. Physical therapy is also an important component of fall prevention, and they can provide gait and balance training. And then lastly, my dream is we can provide referral for a fall prevention class. And you may ask, what's a fall prevention class? We'll come to that in just a moment. So lastly, what are the other downstream effects of preventing falls in addition to preventing those adverse outcomes we talked about earlier, such as fear of falling, functional decline, and so forth? Again, through seeing my world through cancer-colored glasses, falls are predictive of a lot of bad outcomes in older adults with cancer. For example, in this, Dr. Huria, whom I mentioned earlier, demonstrated that falls are a strong predictor of chemotherapy toxicity. And we'll talk about why they're such a profound predictor. In addition, falls are associated with threefold increase of mortality in a cohort of older adults receiving chemotherapy. So for a long time, it was a foregone conclusion in my mind that falls were bad. But I had the opportunity to review a manuscript which was specific to a blood cancer population where they found that gait speed was robustly prognostic. It was associated with increased mortality, unplanned hospitalizations, and ER visits. So in having the opportunity to write a commentary, I really needed to drill down on what is the mechanism for this association. And it actually gave me insight back into my interest in falls. So as I was writing this commentary about why gait speed was so prognostic, I basically went back to what are all of the systems that are involved in walking. And these span from basically the top of our heads to the bottom of our toes. Cognition, we know that patients with impaired cognition walk slower. Patients who are depressed have psychomotor retardation. Patients in a cancer population with nerve damage are going to walk slower. They're going to have less feedback from their proprioception and so forth. We're also looking at things like the musculoskeletal system, patients with sarcopenia, and metabolic impact on their musculoskeletal system. So, and then lastly, cardiovascular function, nutrition, and anemia for delivering the energy to result in walking. So you can imagine that if a person has a slow gait speed, it's a final common pathway for so many different systems that if any one deficit is great enough to impact gait speed, or a small decrement in a number of these converge to impact gait speed, that can be of prognostic significance. And then if you go a step further and think about falls, that falls are basically a failure of the systems to keep everything upright that are needed for walking. Basically, it provides a common pathway demonstrating that one of these systems or a combination of these systems have had a decline, resulting in an increased vulnerability for that older adult. So as I was writing grants to try and get funding to look at this risk prediction, one of the reviewers came back and said, forget risk prediction. This is such a big problem. Just fix it. And so I delved into the world of interventions. And I started with existing effective interventions and kind of scrolled through those and found one that I felt like might be a good fit for older adults with cancer. And then I undertook the process of adapting that. So Stepping On was developed by an occupational therapist in Australia named Dr. Lindy Clemson. And what it is a 7-week group-based self-management fall prevention. It was demonstrated to reduce the rate of falls in older adults living in the community by 31%. It has been implemented on the population level in the state of Wisconsin. And they have demonstrated that in the communities that have more resources for implementing this program, they reduced fall-related injuries coming into the ER by 9%. So this impacted fall injuries on the population level. So that's a pretty impressive program. So what we then did was adapted it to the needs of the older adults with cancer. We enrolled patients who were over the age of 65 receiving chemotherapy or other systemic therapy and reported that they had either fallen or were concerned about falling. And in order to facilitate recruitment, we included their care partners, whether that was a spouse or a sibling. And in one case, we had a 90-year-old and their adult child participated and also felt that they benefited it. And it was really fun to see that this inclusion of the care partners that we originally thought would just be a recruitment tool actually benefited the care partners. And in our first few waves of the study, we adapted the program content, adding in content specific to the older adults with cancer, talking about things, adding additional content about polypharmacy, talking about how that person's heart medicine may impact their blood pressure, and if they've got nausea, vomiting, diarrhea, they may have lower blood pressure and may need to hold that heart medicine, etc. And then we moved on to seeing what outcomes moved pre and post. And our primary outcome in this latter phase being the mini-BEST test, which looks at basically trying to perturb the balance of the older adults, as you can see in this picture here, with trained testers and kind of measuring with a number of measures of their balance. And what we've demonstrated was that the patients had improved balance from pre to post after doing the program, which included components of physical therapy as well, in addition to the program content that I mentioned earlier. We also showed that there was improvement in their falls behavior scale. Basically, the older adults adopted more protective strategies to decrease their risk of falls. And we used a measure of falls self-efficacy. And we didn't see a change in this, but interestingly, it may have been that we just chose the wrong scale because the words are phrased, what's your level of concern, which the participants may have interpreted as awareness of these areas of fall risk. So we demonstrated that our adapted cancer-specific stepping on was feasible in older adults with chronic condition receiving ongoing therapy. It improved their balance and reduced their fall risk behaviors. And heading into this spring, I was all excited to move this forward. I wrote my first R01 to test this in a randomized trial where participants would receive, they would either be enrolled in the adapted intervention, or from all I learned from Eric and seeing how important the medications were in this group, one of the arms was going to have a medication management, medication optimization arm, and then lastly a control group. But then COVID hit, and bringing together groups of older adults who are on cancer therapy became a very bad idea. So that is currently on ice while we see what happens in the rest of the world. But it really does, in my mind, bring it full circle to see how much the depression and mental health and the medications used in sometimes appropriately, sometimes inappropriately, can then loop back and impact the risk of falls. So to summarize and bring us into our question and answer period, depression in older women can be associated with a host of negative sequelae beyond the burden of the symptoms themselves, including perioperative complications, cancer outcomes, and then depression itself increases the risk of falls, which are preventable and which are predictable and preventable. And addressing mental health may mitigate more than just the mental health symptoms themselves. And as Eric has alluded to, and my own research has being halted has shown us, we're going to really need to think of different ways to deliver healthcare and interventions that are rolling with the changes that COVID is bringing for us to innovate and deliver optimal mental health to older women facing surgeries. So thank you for your attention, and we will go to the chat and I'm sorry, to the Q&A to get us started. Okay. Eric, I see, do you? Okay, great. So there's a question here in the comment box about using Xanax or alprazolam, 1 milligram 3 times a day, heading towards surgery. It appears that there's been conversations about tapering it as the patient feels that their anxiety and depression will be worse with the tapering. And how do you navigate that, that challenge?
Yes, thank you. It's a great question. It's a very common issue, and it really gets at the core of, I think, what both Dr. Wiles and I were talking about, which is the what to do about a medication that clearly has the potential for great harm in the perioperative setting, if not in general in older adults. Yet is thought of as notoriously difficult to deprescribe. So I guess the first person I need to convince to deprescribe a medication is me, I guess. So the first thing I guess I would do is say, in this person's case, Xanax, 1 milligram 3 times a day. That is a horribly high dose of medication for an older adult to be taking. And then the second thing to think about, so I would definitely agree with you that this is ripe for deprescribing, and particularly if someone has an operation coming up where falls and delirium and confusion are quite likely in the postoperative period. It's really a critical time to try to deprescribe that. The second is to say, well, why is it? What are the reasons that it's so challenging to deprescribe benzodiazepine as compared to, let's say, if that patient were taking oxybutynin, you could simply stop it or possibly switch it to a less non-toxic bladder medication, and you'd be done with it inside 2 minutes of your time. There's 4 reasons why it's hard. Okay, one is if you just stop a high dose of a benzo, you could kill your patient. So withdrawal symptoms are bad and potentially dangerous. The next is there can be a rebound syndrome. If you taper quickly, you may not cause any medical harms, but there's a good chance that the patient is going to have rebound anxiety and just not feel well. Third is that you may unmask an underlying condition. That is, that the benzo may be, however, imperfectly treating an anxiety disorder or depression. Fourth is, so older adults are rarely literally addicted to their benzodiazepines, although it does happen. But most people who take benzodiazepines on some level like them. And actually the term liking is actually used in pharmacologic literature about the propensity for drugs to cause abuse. I guess on a very real level, the patients are motivated to continue to take their benzo. So here's what I would do. In order to prevent the withdrawal or rebound, I would taper slowly. I would cut by 0.5 milligram every 2 weeks. Now, on the one hand, that may not work out well if they have an operation in only 2 weeks. You're not going to get very far with the deprescribing but I don't see really a way around this slow taper process. The other, though, has to do with the patients liking the medication. I think we should just assume that all of our patients who take benzodiazepines like taking them on some level. And then I think it's our job to let them know reasons why they should dislike taking them. That is, to make them feel motivated to stop them. Older adults are very motivated by things like they're very motivated by the words and the conditions, hip fracture and Alzheimer's disease. And while they may be unfamiliar with the term delirium, they very likely understand the concept of becoming confused in the hospital after an operation. So what I would tell this patient is, I have some good news for you. You're taking a medication right now that puts you at really high risk for having a hip fracture or having your brain not work well, like someone with Alzheimer's disease, or getting really confused in the hospital, if you've ever seen that happen to a friend of yours. I guarantee if this is an older adult, they'll know exactly what you're talking about. They know people who've had hip fractures. They know people who have Alzheimer's disease. They know people who've gone in for an operation and got really confused. And if you tell them that by tapering the medication, that they'll be less likely to have those very frightening outcomes, they will be motivated to reduce that benzo. Great question.
Yeah, Eric, what about substituting a longer acting benzo for Xanax?
It just replaces one problem with another.
Fair enough. Fair enough. I don't see any more questions in the chat. If any other burning questions, let's get them in there. And if not, I'll be turning it back over to Dr. Getty to finish out the webinar.
Thank you very much, Doctors Lenze and Wilds. Your presentations were very thought-provoking, especially as I operate on many older patients. I would like to remind all of you that our next NASPOG webinar will be Thursday, September 10th at 7 p.m. Eastern on the topic of improving substance use treatment in reproductive health clinics. And also, lastly, NASPOG needs all of you in order to advance our mission. Please review the call for volunteers, and please consider applying for any of the open positions and committee membership. I'd like to thank all of you again for joining us this evening, and I look forward to our future webinar on September 10th.